Thank you very much for inviting me to talk. I'm just going to talk a little bit about our experience using the Ventripoint system for managing children with congenital heart disease at the East Midlands Congenital Heart Centre, where I'm very fortunate to work both as a paediatric cardiologist and the deputy head of service there. Just in terms of declarations of interest, I work as a paid independent advisor to the Ventripoint company. So just a little outline about what the problem is that we're looking to try and address with the Ventripoint system. Just understand what Ventripoint actually is, and I'll go through a few congenital heart disease case studies and then invite some questions. So initially, just looking at the problem. Really, it's about assessing chamber size and function on echocardiography, which is really fundamental to managing many forms of congenital and acquired heart disease. It's important for a baseline assessment, very important in assessing the progression of disease, response to treatment, and also, very importantly, for the indication for surgery or intervention. Current practice, well, I think we all know what we do. Usually the eyeball subjective assessment. We have our linear measurements, our left ventricular internal dimensions, fractional shortening, and our volume measurements with biplane Simpsons. And also we have the availability of myocardial deformation imaging to assess function. These all have drawbacks, however. There's quite a lot of subjectivity in the assessment and the reproducibility of these results. Many of the techniques use a lot of geometric assumptions which may not necessarily work well, particularly with certain pathologies where you may have abnormal geometries. They're dependent on getting complete echocardiographic windows, which we know can be very, very challenging. And in certain modalities, normal data is variable and can be vendor dependent. We also have a lot of inter-observer and inter-study variability. And what about the right ventricle? Again, as a congenital cardiologist, I rather like this quote. I like to think of myself as being a holistic practitioner, a holistic cardiologist, because I treat both of the ventricles. So the right ventricle actually has a very complicated shape, and you can't make simple geometric assumptions. With the left ventricle, because it has this conical shape, there are a fair number of fairly valid geometric assumptions you can make, but the right ventricle has a very triangular shape. It has an inlet and outlet portion, and also, very importantly, with different pathophysiologies, that geometric shape actually alters substantially. So there's no good volumetric measurements of the right ventricle on standard 2D echocardiography. We have a few fairly limited ways of assessing the right ventricle. It does tend to get a little bit ignored because of this. We can measure the TAPSE, free wall tissue Dopplers, but these are not representative of the entire right ventricle. And also, for a lot of our patients who've had stenotomies, we have adhesions, we find that actually that area of the right ventricle can be adhered to the anterior wall of the chest. Fractional area change, well, we're only looking at a very, very tiny part of the right ventricle, and also we've seen a lot of inter-observer variability with that. There is some work being done on myocardial deformation imaging. However, all of the vendor solutions thus far only look at the septal and anterior walls, so we're missing all of the information about the inferior wall, the anterior wall, and also this doesn't give us information about chamber dilatation, which is a major aspect of when we're deciding on indications for intervention. 4D, well, I don't know how many people here have actually tried to do 4D assessment of the right ventricle. It is very challenging to get adequate views, particularly in patients with pathologies, with dilated ventricles, because you have to try and capture the whole of the right ventricle in one image acquisition. The RV is really important. As a congenital cardiologist, it's often the most or only affected chamber in congenital heart disease. We have a large number of patients with tetralogy of Fallot who, following their repair, are left with severe pulmonary regurgitation, and there are many, many debates about the correct timing to put in a pulmonary valve replacement in these children and young adults. We have a lot of patients with right ventricle to pulmonary artery conduits, and again, it's how long you leave those conduits before they need replacement is really critical to how many operations you're subjecting these people to versus trying to preserve the function of the right ventricle in the long term. And we also have coming through a lot of patients with univentricular right heart circulations, in particular patients with hypoplastic left heart syndrome, where they are reliant on this one ventricle to get them through life. And if we don't have a good way of accurately monitoring that over the long term, we're really doing a disservice to these patients. And also, in common with adult practice, we do have a proportion of patients with pulmonary hypertension of various etiologies. And for these patients, we know that right ventricular ejection fraction is a very important predictor of their outcomes. We also know that for many other diseases and in critical care, that right ventricular function is an independent risk factor for survival. So really, it's the forgotten ventricle. I really spend a lot of time looking at this. Existing solutions, well, everyone knows that we can do cardiovascular MRI imaging. It is the gold standard for measuring ventricular volumes. However, I don't know about your institutions, the access to it is relatively limited, particularly if you're looking at response to treatment and doing serial scans. Not many people are going to have access to MRI for doing multiple scans per year on a particular patient. For us, as well, in younger children, MRI scanning is poorly tolerated. Really, under the age of about 10, we struggle to get children to stay still in the MRI scanner, let alone do breath holds and get accurate data. People with claustrophobia often don't cope very well, and in patients with learning disabilities, again, we find that we have to use general anesthesia to perform MRI scans in these patients, which again limits it as a practical way of doing these serial assessments. We also have patients with various contraindications. Pacemakers, yes, there are a lot of MRI-compatible pacemakers. However, they do produce significant image artifacts on MRI scan. And we also have a lot of patients with epicardial systems where the systems themselves are not MRI-compatible. And we have a certain proportion of patients who maybe have retained temporary pacing wires in whom we can't do these. So whilst MRI is excellent, it does have a lot of limitations in practical day-to-day life. I've already talked about this real-time 4D echocardiography, which I think a lot of the vendors are purporting as a very good way of measuring right ventricular function. Again, it provides that complete assessment without the geometric assumptions because you're measuring the whole heart. However, it requires seeing the whole of the endocardium for the entire right ventricle through the duration of the cardiac cycle. And for those of us who do 4D echocardiography will know exactly how much of a challenge that is. And actually in studies, the finding that you can get accurate data on patients, only a relatively limited number of patients you can actually get this data for, which I think really makes it very, very limited. In patients with severe right ventricular dilatation, which are really a lot of the patients that we're interested in, the imaging is even more challenging because you've got a very, very large heart that can actually sometimes be bigger than the scan area that was provided on the 4D echo. So this is where Ventripoint comes in, which is really quite an elegant solution for looking at these things. It's an adjunctive system which you use alongside your 2D echocardiogram. And what you're doing is that the system is monitoring the position of the echocardiographic probe in 3D space whilst you're taking these acquisitions. What this means is that you can take multiple acquisitions from different windows, put them all together at the end of the study, and generate that volumetric information. The way it does this is you mark off points on the 2D echocardiogram which correspond to anatomic structures. And there is a 3D knowledge-based reconstruction algorithm based on MRI imaging, which then uses a mathematical model to populate these 3D points in space and generate a right ventricular volume from that. Another big advantage of this is that if you can see certain structures from some views but not in others, you can put all that data together. You can also utilize images where you may not see the entire of the heart in one picture. So for example, you can take one picture focused on one area, for example, the inferior wall, one area focused on the anterior wall, and put all that data together. So it basically combines the usefulness of the volumetric measurement of MRI with the ease of echocardiogram, and it's very simple and straightforward to do this in an outpatient setting. So we get the high frame rate, the excellent image quality that you can get from taking multiple images of the same structure and using the views that have the best pictures of the structure of interest to put together all that data. The the algorithm is trained on a library of hearts, including multiple different pathologies, including patients with conduits, with pulmonary hypertension, with Ebstein's anomaly. So the software is trained to be able to detect all these different ventricular shapes and take them into account when processing the data. This is just a demonstration of the system in practice. You put a sleeve on the ultrasound transducer. This is the old version of the platform, but what you can see is that there's a magnetic emitter. The detector, which is attached to the probe, tracks where it is in that magnetic field, and you can see here how it's moving that dice in response to where the probe is located in 3D space. Once you've acquired the images, you find the end diastolic frame, you pull across the anatomic points. This is a 4-chamber view looking at the right ventricle. We're marking off the mitral annulus points, the lateral wall, the septal wall, and the apex. There we go. And then we go to our end systolic frame. We mark off the same points on this one as well. Using these templates, it's quite straightforward to place these points. And you do this on multiple acquisitions. So the next frame we come to, we'll go for a short axis view. Again, this is a short axis view focused on the right ventricle. We pull across our template for our short axis view, where we can mark off again. We've got septal points, we've got anterior wall points, and these are markers which demonstrate the edges of the septum, just as the right ventricle is inserting into the edges of the septum before the left ventricle. We mark off these points here. I've not shown you all the windows we do this on, but you do for a right ventricle, you take around about 6 acquisitions. Once you've done that, this is just a demonstration of all of these acquisitions where we've positioned the points. We then click on, we see the end systolic and end diastolic frames. We then click on the calculate button. There we go. And what this does is it feeds these points. So the system isn't looking at the pictures. All it's doing is looking at these points, which are located in 3D space. And it puts them through this knowledge-based reconstruction algorithm. And what you get at the end of it is actually a volume which is based entirely on these points and not on the images that you've taken. It's literally just looking at these points. When you actually have a look at this, you can see that these are the scan planes in that 3D space, so you can see how it's put together, all these different scan planes to get that information together to generate this 3D volume. And we can also look at the end systolic image. And this basically gives us an end diastolic volume, end systolic volume. We can index those to body surface area, which the software does automatically. It gives us an ejection fraction and a cardiac output based on that. This isn't tracking this is using the heart rate to just animate that, but it gives you a good idea about which area of the heart is moving between systole and diastole. And then what this is an overlay of that 3D model on the 2D images to demonstrate how they intersect and run through that, which you use as a way of reverse validating the results. So here you can see in relatively few stages that you can get these accurate RV volumes. You can also, of course, do the same thing on the left ventricle. Again, it's a very similar process. We take multiple acquisitions. We mark off the points in the ventricle. We use the reconstruction algorithm, which is tuned to the left ventricle. And again, this is really useful as well because, you could have a patient in whom it's very difficult to do a biplane Simpson on the apical views. You may see the mitral valve annulus on the apical views. However, your endocardial borders may be better seen on your parasternal short axis views. And you get to combine the two because we've registered the information in 3D space. Here we can see a parasternal long axis view and a short axis view, and you can see how they're registered together to get us that overall image. And we come up with our systolic and end systolic and end diastolic volumes and our ejection fraction on the basis of that. In terms of how it correlates with cardiac MRI, it's been the subject of studies, and it has been clinically validated to correlate very well with MRI measurements done at the same time. So we can see excellent correlation here. And this is our own data where we've done an inter-observer variability check between myself and one of my colleagues. and we're finding that we get a very close correlation with very low inter-observer variability. So we're very happy as an institution that the information that we get from this is reliable. Obviously, you do have a certain element of garbage in, garbage out. So if you do not see the structures on your scan, you can say that we don't trust these measurements, but that's the same, I would hope, with any echocardiographic measurement. So this is the old system. We've been using this system since 2015, and we've generated a lot of experience with it. However, you can notice that the IE33 echo machine here, you see that the Ventripoint machine situated next to it was quite large, quite cumbersome, and that really limited its use for outpatient echo scans only. So we were using it quite extensively for following up our patients with tetralogy of Fallot with pulmonary regurgitation, and found it very, very valuable for that. However, late last year, I got the delivery of a brand new present in a lovely big box. It didn't have a bow on it, unfortunately, but this is me taking a selfie with the new system here and showing it with my other colleagues in the imaging department at the East Midlands Congenital Heart Centre, and you can see that this is substantially smaller. Here you can see it in our outpatient clinic room. It barely takes up any room at all, but that's us in captivity, and now I've been allowed out into the wild. I can stalk the hospital, and I'm now very dangerous being able to run around, being able to do these scans on lots of different patients. This is an example in our intensive care unit. I used a simulated patient because I didn't want to ask any of the babies there. However, what you can see here is that we have an ECMO circuit set up here. We have a relatively restricted space in our ITU, but I have done multiple studies on babies in the intensive care unit with this equipment, and it's very easy to set up, very mobile. And it gets us this really accurate, informative data, and I'm very excited for the prospects of using this in the future. In particular, I'm thinking about ventricular function in post-operative patients and in patients on ECMO, and how this can be used in clinical decision-making on the intensive care unit. So I just wanted to present a couple of quick case studies just to show you the sort of information that we can get. And these are a couple of patients with tetralogy of Fallot who had slightly different clinical courses. The first patient is just a demonstration of how we're using this to monitor patients serially with tetralogy of Fallot pulmonary valve regurgitation. And this is a patient who remodeled following. So this is a fairly typical story for a patient with tetralogy. They underwent a repair at the age of 11 months with a transannular patch, which for those of you who don't know, basically involves effectively removing the pulmonary valve. Now, these patients do very well in the medium term because they resist the pulmonary regurgitation quite well. However, as they get older, the right ventricle becomes progressively more dilated, and the concern is if you leave that progressive dilatation, there will reach a point where even doing pulmonary valve replacement, you may not regain the function of that heart. So a lot of concentration is put on when is the optimum time to do this. We know early pulmonary valve replacement in children leads to those valve prostheses not working quite quickly. So we want to leave that as long as possible, but we don't want to leave them to the point whereby we don't get that remodeling happening. So as a routine, this patient had an MRI scan at the age of 12 years, demonstrated an indexed RV end diastolic volume of 129 mils per meter squared and an indexed end systolic volume of 59 mils per meter squared, and they were generally asymptomatic at that time, which is fairly standard, not unexpected, and we wouldn't push forward with an indication. We tend to have an indication of an indexed end diastolic volume of above 150 or an indexed end systolic volume above 80, or we consider at lower levels in patients who are symptomatic. However, at age 14 years, they demonstrated a reduction in their exercise tolerance. For various reasons at our institution, we had limited access to MRI, so we took them forward and looked at using our VMS system. This demonstrated a significant progression at that point, which correlated with this increase in symptoms, with an indexed end diastolic volume going up to 170 and an indexed end systolic volume of 92. So we actually put them forward for a surgical pulmonary valve replacement. And here you can see the progression where we have measured, using our Ventripoint system, the indexed end diastolic and end systolic volumes. Obviously, the kid's growing at this time, which is why I'm using those index values rather than the absolute values. because by correcting them for the body surface area, we sort of remove the impact of somatic growth here. However, if we look at the point at which the pulmonary valve replacement was performed, we see a dramatic reduction in that diastolic and systolic volume, which is what we'd hope to see. And actually, we have relatively stable volumes up until that point. And as part of their regular follow-up, we performed an MRI scan towards the end of that, which just shows very nice close correlation with those figures. Again, that just provides us some reassurance that these numbers are useful. And we can continue to monitor this as we go forward in the future, and potentially more frequently they do on an MRI scan, able to pick things up earlier and intervene as necessary. Here's another case where we had a patient who didn't remodel following their tetralogy. Again, a very, very similar story, a patient with tetralogy, which was repaired again with a transannular patch at around the age of 9 months old. They had a routine MRI scan at 9 years old with a slightly higher end diastolic volume of 144 and systolic volume of 85. And again, became more symptomatic at around the age of 12 or 13 years. And they demonstrated a significant reduction in their cardiopulmonary exercise test parameters with a VO2 max of 23 mils per meter squared and an oxygen pulse of 6.1 mils per beat, which is both significantly below where we'd expect them and are good indications that the cardiac output is limited. We did an assessment at the age of 13 years. Again, I think at this point we have the index values are slightly difficult because you have a lot of somatic growth in this time. So the absolute values versus the index values can change substantially. But this, because of the symptoms and the CPEX, this boy was put forward for pulmonary valve replacement at the age of 14 years. And here again, we see that progression. We did the pulmonary valve replacement, but unfortunately, we didn't see much of a change in the end diastolic volume or the end systolic volume, which continued to increase with relatively impaired function. However, symptomatically, he did better following this. And again, we performed an MRI scan as part of that follow-up, which again shows very close correlation with the figures we had. So this just means that certainly for us as an institution, we're able to keep a closer eye on these patients, and potentially when we're looking at many of our patients can actually just make better decisions on when we do these pulmonary valve replacements. There are just a few references which I'll put up. Here's a few studies just looking at the use of knowledge-based reconstruction from the 3D data as well as 2D data, and correlating it with MRI scans. Okay. So does anybody have any questions for me at all? I don't think we've got this. Hello. Sure, sure.
But does it just give you volume data per se, or can you get information like inflow to outflow relationships and geometry of the right ventricle in that way?
Yeah, I mean, you can assess that visually. It doesn't give you measurements, and unfortunately you can't do those measurements on the system. I think there's no reason why you couldn't do that with that data. That's just not something that's provided at present.
Where maybe there's a predominant type of outflow enlargement in pathology.
Yeah.
It would be useful to try and establish those sort of relationships.
Absolutely. I mean, one of the things that's actually really quite interesting is that some of the future work that's going on is actually looking at the differences between that end systolic and end diastolic volume. And what we're seeing, particularly for those patients you're thinking about RVOT, aneurysms with ARVC, is what you may find is that the size difference between systole and diastole actually isn't changing, and what you'll see is that on that motion, I don't know if you saw my slide where we saw the animated motion between the end systolic and end diastolic volume. Now that's a little bit synthetic because that's only assuming the motion between the two based on the heart rate. But it does actually give you that impression that you can see visually between the different parts of the heart moving between those phases, and you can actually just get quite a nice visual representation of that. And I think with the ARVC patients, what I'd expect to see is an aneurysm that's non-contractile in that area.
Even beyond, I guess, functional elements, is that structural? Thinking about different load challenges, so where you've got preload increases such as pulmonary regurgitation, just how that it's very nice. This would be a nice way of kind of making it a little bit more detailed.
Yeah. No, absolutely. I mean, I think there's a lot of potential here, and I think actually the 3D tracking of a 2D probe also has a lot of applications as well, which I'm quite excited about. Particularly, just one of the weaknesses of echo is that you can see some things in some views and something in other views. And I think being able to combine those images together is really powerful. Now, that's what we do when we're presenting an echo. We say, oh, don't look at that bit on this echo, look at this one. But if you can combine those two things, and when you present them, I don't know, it's sort of that picture where we put the different planes up against each other. It's really, really useful, and actually it keeps you very honest. I find it a very useful learning tool because you see from that where your assumptions are wrong. You see certain times where you've maybe marked off a point, you think, okay, that's the lateral wall of the ventricle, and actually you see it doesn't correlate with something else, and then you realize actually that's papillary muscle. So it's very, very useful from that perspective as well. And I find it a really useful teaching tool for myself as well as other people working with us. Any other questions? Yes?
Hi there. I suppose thinking...
Oh.
Right, sure, don't need a microphone, that's okay. Thinking pragmatically, most of the patients we see in congenital clinics, they come as a one-stop service. How does that work in an outpatient environment, and what happens to those images that's on a separate screen? Do they feed back into the database storage, such as echo packs at ISCV? So 2 questions, but...
Yeah, so what actually happens is the older version of the system used to take a video out from your echo machine and process that through the machine, so you'd have to calibrate the machine. The new one actually has a DICOM pathway where actually you export the DICOMs from the machine onto the Ventripoint machine. What happens then is that it combines the position data with the DICOM data. You can then save that if you want onto a network drive, where you can post-process that at leisure, and then there's also facility to upload that onto a PACS server as well. So you do have that ability to export that final result. We don't do that where we are currently because it requires IT engagement, which always is the death knell for any project, but it's perfectly possible to do that. We do have a separate workflow where we have a machine where we're sending these studies to that we use for processing them. What it outputs is it also outputs a PDF report which gives you all those volumes on it. So what we tend to do is rather than storing the images on our PACS servers, we output the PDF onto the electronic patient record, which has all that data on it. I mean, one of the things I didn't cover here is it does do right atrial and left atrial volumes as well. And you can have a whole report which will have all 4 chambers giving the systolic and diastolic measurements on it. Does that answer your question?
I'm just thinking of how streamlined the process is in the real world.
It's relatively streamlined because what you do is you have say for example in an outpatient clinic, you have the machine there. The VMS machine is connected to the network. Your echo machine is connected to the network. The workflow is that you do a study, you take these required images with the machine active. So, and what you're doing is as you're taking the pictures, you're clicking on the machine saying, I've taken a 4-chamber picture, I've taken a short axis picture. It knows the point in time when you captured those, and it marries that with the DICOMs that come off the machine, and then the machine will send those via the network onto your remote hard drive, and you can have your reporting station set up. So you can have your reporting station for your normal workflow. It will run the same software to do the Ventripoint data on that one, and then you have an archive on a network drive, which is secure and has all the privacy systems for that. So it's actually, it sounds complicated, and it's a little bit complicated to set up, but actually once you've got it up and running, it is really quite streamlined. It does add an extra step, but I think the value of that data that you get over it does add an extra step above doing a normal transthoracic echo, but actually I think arguably, how long does it take to do an MRI scan? How long does it take to report an MRI scan? I mean, the hours that you spend drawing circles on short axis views. The other thing that's really interesting about this, which I didn't demonstrate, is you can import an MRI data set into this as well, because all the MRI acquisitions are acquired with registered 3D space relative to one another. You just take the MRI scan, you import it into the system, you do exactly the same thing, you place those points. That's a really interesting way of doing it as well. Any other questions? Okay. Thank you very much then.